Welcome back, everyone. I'll ask everyone to take their seats for the next session. So our next session is going to focus on implementation and adaptation of comprehensive care models. And we hope that this session will enable the group to gain insight into the many ways that CCP models can come to life at different organizations and provide a framework for sustainable implementation and scaling. And I'll now turn it over to Francis Balukin, who's going to be our first presenter. Thanks so much, Francis.
Thanks, Andrew. My name is Francis Balukin. I'm at Vanderbilt Medical Center. I am actually transitioning to Cigna, one of those bad actors in January, as being home-based primary care. So I'll be dealing with the same population too. But thanks so much for inviting me. I think I just want to give you guys a big framework of how we implemented comprehensive care at Vanderbilt. We've been in existence since 2017, and we've learned a lot. I think there's two key points I kind of just want talk to you guys before I start talking with you about my big framework. Every journey will be different. So when I started 5-6 years ago, I was looking for a journal article that would tell me, how do you get from A to B? It doesn't exist because there's so many nuances that would happen. I treated comprehensive care more as a philosophy, and how do I leverage these relationships between patients and with colleagues to improve outcomes. The second thing that I kind of want to say is frameworks. We are good with frameworks. When we talk about shock, a shocky patient, we have a vision about what it is. I want you guys to consider looking at other industries. When we say a business is failing, we have an image of what that looks. There's no items. There's a lot of turnover. I knew Bed Bath & Beyond was, not doing well. But I want you to kind of explore all of these industries and compare it with healthcare. What are the similarities? What are the nuances? So I think I start with those two first statements. When we're implementing comprehensive care, what we're talking about is basically change. We're asking our health systems to go from this pathway to something different. So the framework that I'm using is basically change management. You have to create a sense of urgency. When I talk with different people, I tell them what's going on in other industries. We know in the film industry, there's all of these, companies before, Lionsgate, Universal. I watch most of my stuff from Netflix and Hulu now. Do you honestly believe healthcare would be immune to these changes? Now you see it at the hospital right now, how congested we are, how the emergency rooms are right now, how our length of stays are. When I wanted to see my primary care, I couldn't see him in 2 months. If it's not affecting you, think about it, how it's going to look in 5-10 years. So when I talk with people, I tell them there is urgency because it's our lives, our families' lives, it's our patients' lives at stake. When you talk about convincing people to change, there are different visions of change, and you have to acknowledge that it exists. Not that I like it. There is a vision that, Francis, stay in your lane. Just come to the clinic, do your stuff, go home. It's not your job to change healthcare. The other vision is status quo, meaning, Francis, this is how it's always been done here in this whatever institution. Why change it? Why rock the boat? I think I'm here to convince you that there could be another vision, right? And then that's why we're here today. You're here. We flew all the way from Nashville because we are convinced that there could be another vision. And I think the thing that I want you to think about as a clinician, as a patient, as a section division, chair, is what is your vision for healthcare? How does it align to what it's going? I want you to just intentionally think, is it aligning to what I think healthcare should be? I present to you a vision. And when I go to other groups, this is what I tell them. This is the vision of change that I'm thinking about. Talk about value-based care. The problem with this, it's so buzzwords. Like when I heard about this, 6-7 years ago, I didn't know what that means. It's very vague. Like, how do you do it? How will it affect me? It's this increased outcomes or decreased costs. Like, what does that mean? I think what I try to do with our group, and when I talk with other people in Vanderbilt, is I brought granularity to what it meant. So basically, I said, value-based care in my situation, in my group, means we had a defined population and we have outcomes and costs that are attributed to this. Now, this is not like from a textbook or anything. We literally discuss it as a team. So I think what I encourage you is to kind of figure out with your group, with your population, what does that mean? We are dealing with different populations. Tennessee population is very different than the Chicago population. 30% of our patients in the hospital are not from Nashville. They're in rural counties that don't have a hospital, which is probably very different than any, with other hospitals. So all of these things are very different. The outcomes are very dependent on your group. Like what was important for your group? Retention was important for us. Patient PROMs is very important to us. So I think very important is to intentionally think about these things, when you're talking with different people. The other thing, when you want to bring granularity to your framework, you have to use the available data that's in your electronic data warehouse. There's all of these fancy data that you could see from literature. I think I advise you to kind of look what's available first. One of the most important people I've met in Vanderbilt was Enterprise Analytics, because I've learned that they have access to all the data and they're able to kind of produce every graph that I wanted to, as long as I built connections with them. So I met them like 6 years ago when we were starting, and they were helpful. The other source of data is like finance people that could give me all of these other financial data. And it's not like, I wish there was like a paper and say, these are the connections that you have to meet. No, you have to kind of snoop around and say, who's this nice person? So figure these people out, and this would give you the data. When you're creating the vision, I want you to think strategically, what is the population that you want to target? This framework is from business. And if you think about it, with a lot of other industries, other businesses focuses on like certain populations. Whole Foods focuses on different populations than Kroger's. You can't find vegan, stuff at Kroger's. Well, I think you could, but the point is you have to think strategically, what is your focus? For Vanderbilt, for our group, we focus on a very specific population because we know Vanderbilt is getting most of it. We're not trying to be the Oak Street, or Oak Hospital. We're focusing on the high need, high cost populations, meaning those who have 10, 15 diagnoses, those that no one can handle in the hospital. And so when I talk with different groups, they know exactly what I'm trying to do. And basically the value proposition that I tell them, I take care of the most complicated ones. That's why we need this funding. The other thing that I want to encourage you is to target populations with the worst disparities. I like this quote from Clayton Christensen. He talks about disruptive innovation. So he basically mentions to target, that population that no one wanted. I know at Vanderbilt, and everyone knows about it, but no one talks about it. The population that I handled, no one wanted. So there were no committees when I wanted to implement change. So I want you to think about it. There is that population that no one wants, but no one wants to talk about. When I communicate change, I have a formula then. It's very easy that I repeat. I deal with a focused population, and comprehensive care is the way to do it because I have the same team, longitudinal relationship, and whole person care to improve value. I have 3 minutes, but I kind of just want to go through this quickly. After you have the vision, you have to find people, your army to help you do this. It takes a village. I encourage people in the group, if you are in a position to hire people, look for intrinsically motivated people, but make sure they're supported. Once you find a bigger pool of supported, people that are, like that, find the do-gooders and the go-getters. I encourage you to resist micromanagement because this is a very difficult task. You wanted to give them a lot of freedom, to figure out how to do it. I also encourage you to start small. Smaller teams disrupt and larger teams develop. It was easier for me to convince 10 people to get into a vision than 200 people. So I think design the smallest team possible with diverse viewpoints and complementary skills. I think that's the other key thing. Our group's voice is not just physician voices. We have nurse practitioners, pharmacists, social workers, and nurses, and we want to make sure the voices are level. 4, when you're starting a program, you have to kind of understand there are allies and old guards wherever you go. There will be people that would resist any change that you want. Now, whether you like it or not, they exist. I don't focus on them. I focus on my allies. And eventually these old guards come to me. So cardiology and heme onc before hated our program, but now they're referring to us because they needed us. So it just expected. So I don't, feel bad about it. Well, I do. Too bad. Too bad. That's true. Number 5, you have to create a cadence for removing roadblocks. So weekly we have a meeting. So I encourage you to have like a weekly meeting to kind of discuss all issues, review data, and get everything out. We also have a yearly planning to kind of see, okay, what are you guys wanting this year? Because we all have our lives and different things. We just want to make sure everyone's like growing at the same pace in the same direction. This other thing is you want to stagger wins during your journey. This is not going to be a straight line. I use this startup curve to kind of demonstrate how it feels like. Basically, you'll have this initial excitement, but there's going to be this phase where, everyone wants to leave. Expect that, but stagger all of these wins. We didn't put all our wins in the second year. We did it, every year so that people sustain. So you have to manage the team's energy and disseminate wins and make sure all of your team members are sharing the wins and create collaboration. So we've partnered with all of these groups to kind of make sure that, they know that we're doing something good. And then, the last couple of slides, you just have to sustain acceleration with data. I'm saying data is very powerful. I'm showing here our early discharges, from our group from the last 5 years, and this length of stay by our group. Ours is the orange group. We've really improved outcomes in the hospital for this. This is something that we're very proud of. We had the physician scientists do a propensity matched model for patients using our data warehouse that was not enrolled with VICP, and to those who are enrolled. And we did show, improvement in hospitalizations. It's, one of our physician scientists submitted it for a journal. I think the data is important to connect the anecdotes to the vision. And then the last thing, you have to make it stick. You have to create the identity of comprehensive care. And that's why I'm thankful for David for organizing these things, because we want more physicians, nurses, case managers, social workers, pharmacists to believe in this model. And most importantly, patients who also believe in this model, because they are going to be our best advocates for comprehensive care. And that's pretty much it. Thank you.
Sorry, I can't figure out how to turn this. I have my phone on mute, but obviously technically sorry. Okay. So I'm very appreciative to have been invited here today. I'm Cressa Parrish, family practice physician for about 38 years at Ingalls Hospital, community hospital south of Chicago. And it's inspiring to see all of you here and to understand how comprehensive is this approach, because I think it's very important. So my short discussion will be on the implementation of the CCP program at Ingalls Hospital. And this is a letter, but I don't think we have time in my 10 minutes to read it. But I have received over the years multiple statements of appreciation for the continuity of care that I've provided for patients, because I, throughout the career, had the CCP model before it had a name. And I'm very grateful that this is something that is being championed now, because I saw the benefits of understanding the patient's support network and where they exist in their health care and what I can do to impact that in a positive way. So Ingalls Hospital is celebrating its centennial year this year in the community of Harvey. And it has been a major employer of residents in the community and surrounding area for all those years. As you can see, Harvey has a population of about 20,000 now. It has been dropping since the Rust Belt hit, basically, and industries have left gradually. 66% Black or African American, 25% Hispanic, which is the growing portion. The income you can see is low socioeconomic level, and the employment is also relatively low. We saw an opportunity to make a more systemic and sustainable approach to providing care continuity for the patients that accessed Ingalls, and hopefully to also attract other patients who would either use the emergency room or one of the 4 satellite in Ingalls Urgent Aids for their care, because I am a champion of primary prevention. As a family practice physician, I think that is the key to health. And yes, we have to address everyone who's ill because they didn't sometimes make choices that were in their best interest early on, or they unfortunately had genetic issues. But I think the continuity of care builds that trust and bond and freedom to express their needs or concerns that is very valuable in their overall care. So we saw this opportunity to maybe attract more patients to the Ingalls system and possibly have fewer hospitalizations for them. And also it's a value to the physicians who are going to participate in this, and it's a value to the hospital revenue stream. So basically, I think the community hospital is critical in an area like Harvey. There are a couple of hospitals scattered around, but each of them has its strengths. And Ingalls has over the years been very strong in specialty care and in primary care. So we thought it was a good model to attract a CCP program to. So I think that basically covers that slide. The implementation timeline is here. The initial planning involved David, Emily, and myself discussing, does this seem like something that could potentially be accepted at Ingalls? I was very much in favor of it because I knew that my call group was basically providing CCP care already, and it should make it a more seamless transition. And so we identified some physicians who might be interested, had a presentation for probably 30 physicians, and just discussed the model. Some more interested than others, but at least we reassured the others that we weren't going to suddenly suck up all their patient panels, which was kind of a concern initially for the administration and some of the other physicians. We then identified the initial recruitment strategy for physicians and for patients, and the inclusion criteria for both as well. The second step, the institutional buy-in, it turned out to be the most challenging because we had just merged with University of Chicago several years prior. So there were seemingly constant changes in the upper levels of administration, and we kept having to represent this same model to a new set of decision makers. But eventually it stabilized enough that we could get acceptance, and then we created the pilot program and had a call group of 4 physicians, including myself, and gained funding for some AmeriCorps members so that they could be our support team. And they were crucial to our existence. So I feel something like that is a relatively efficient financially way to go, but it's attracting a very dedicated group of individuals who are, they tend to be excellent at communicating with the patients so that they can assess their care gaps, their needs, their wants, their complaints, and then communicate it in a meaningful way to the providers. And that, I think, is the key to making a CCP program successful, is the communication that can exist among all of the providers and the patients, with the patients feeling like they are the central voice, which I think is very important. So the AmeriCorps workers were able to perform the recruitment function at Ingalls when a patient was admitted, or when we got the emergency room physicians to agree to promote our program as an option for unassigned patients so that we could attract beyond our own existing panels. And then the AmeriCorps workers collected the data and helped to coordinate the social service support resources. They did not take the place of the social service people or the care coordinators, but it took some of the burden off of those people, and it helped to more granularly identify the needs, both as inpatients and outpatients. And then the ongoing operations, we still have that group. Even since I've retired, someone took my place, so we still have a 4-person call group. and the AmeriCorps continues. They shifted to more of an AmeriCorps older population because they were having problems with transportation with the younger AmeriCorps members. So over time, I guess that has shifted a little bit since I was there a year and a half ago. But and as I said, we were adding new patients to the system. So there's a list of the doctors who were there when I was there. The CCPs basically round on their own patients Monday through Friday in the mornings and see their patients in their clinics or offices in the afternoon. And then every fourth weekend call to see our 4 panels of admitted patients. This is also helpful if someone's on vacation or has a leave of absence for some reason, because there's still some familiarity with these higher risk patients who've been in the hospital and met the other physicians. The rounder model can also support that, where they might round for other people's patients in the hospital so that at least there's some familiarity, and it kind of expands the panel to physicians who don't want to round in the hospital, but still would like that continuity so that it's not the rotating hospitalists. The research design is an observational study surveying patients about their experience with care. It's done at baseline 3 months and then every 6 months in perpetuity for as long as the patient participates. And we had about 109 patients enrolled, mostly from the CCP's existing panels, but 15% without a prior PCP. So we're making a little headway in what I would consider an option for primary prevention for diseases, which is, you know, what I try to emphasize in my office as much as possible so that I don't have all these hospitalizations. But it's such a longitudinal approach that you're not going to see it immediately. And we've already talked about the AmeriCorps workers' roles. And I think we've covered this slide pretty well also. So we hope to expand our recruitment to approach more hospitalized patients. I think the intention now is to attend more community events to promote the program. There has been involvement with the mayor and other local state politicians in order to promote the program. And then we have this, it's not on this slide, maybe the next one, but so the Wood Street corridor survey, Wood Street is the street that Ingalls Hospital is inhabiting. And so about, I think it's a 13-block perimeter around it has been surveyed for residents regarding their needs and wants and how they see Ingalls impacting their lives and what desires they might have for future programs, which is very helpful. Also, and this has been in a door-to-door effort, so the patient feels free to express their opinions. Also, there is a fairly tight bond with the Ingalls Development Foundation, which is the group that is the major fundraiser for Ingalls projects, and then the Wood Street corridor. And I think it has been very successful in its initiation and hopefully will continue. So that's it.
All right, great. Just want to make sure we can advance slides here. Perfect. David, Emily, thank you very much for the invite. Really nice to be here with all of you. My name is Neeraj Mendiratta. I'm APIC. I'm a Permanente physician with Kaiser Permanente in the Mid-Atlantic states, service chief for the complex care program and principal investigator. So I just want to give you a little bit of an overall view. Lucky me, I'm sitting next to Ali Khan, who knows more about Permanente medicine than maybe even I do, so I won't embellish too much. He'll call me out on that. But in the audience, we do have Dr. Doug Roblin, who's our senior scientist, so we may have some questions for him. So an overall view for Mid-Atlantic states, you guys are very familiar with Kaiser Permanente in the West Coast market, which is like 51% of the healthcare market. But up and rising, we are here in the Mid-Atlantic states. We have 830,000 patients. We have about 1,700 physicians now. We don't have our own hospitals. Well, we have hospital partners. So this is our breakdown. The DMV, DC, Maryland, and Virginia is what makes up the Mid-Atlantic states. So, we have, as I mentioned, we have like 13 hospitals that we partner with, but really the bread and butter of KP Mid-Atlantic states is our Kaiser Permanente hubs. We're an integrated model with, as I mentioned, 1,700 physicians, subspecialty included. And then we have a cheesecake factory of menu of skilled nursing facilities, which we are working really hard to narrow down to our what we call core, where we have our own physicians rounding. So really a truly integrated model. A patient goes to the emergency room, gets admitted, seen on the Kaiser floor of that hospital, then discharge goes to a Kaiser affiliated skilled nursing facility, and then goes back to the continuum. So I think we've gotten that down right. And then our AUC, Advanced Urgent Care. So these are our, what do you call it? Urgent care on steroids, maybe. We hold our patients for about a midnight. And we're able to turn around a lot of things and avoid hospitalization. So one would say that, hey, this seems to be a perfect model for, you have unfair advantage. But interestingly, as I heard David's opening remarks, we end up in the same place. We have the same challenges with proving the utilization benefit, right? So I'll talk a little bit about that. So the overall view, I think David and Bernadette Loftus probably had a conversation sometime in 2017, and earlier probably, and she was convinced this is the way to go. She met with me and said, "Make it work." So yeah, so we can say no to Bernadette, and so we made it work, and I'll show a little bit of a pilot study for you. But fast forward in 2018. I was able to recruit 9 physicians and the DMV that would do this amazing work, each one of them empaneling 200 patients with a group, with a supporting staff. In 2021, we published showing a pretty significant survival benefit, but not an increased utilization, but a status quo. That was a 6-month study comparing to folks that joined complex care and those that didn't, with a propensity matched equivalent CMI. And then in 2023, we're hoping to publish again, showing similar results, but the much higher end of patients. This is what sold the study, right? So we did a pilot. We took 424 patients and 2 very courageous hospitalists that said, all right, I think I want to know what it means to care for these patients sort of in a concierge model. We're not fee for service, so we don't use the word concierge much, but it's all included. It's included in your Kaiser insurance plan. So what we were looking at, just any other organization would want to look at, is utilization, hospitalization, readmission, trips to the emergency room. So we looked at that, and you won't believe it. Like, everything looked amazing. The blue line is hospital admits. The gray line is ER visits. CDU, we used to call them CDUs, but they're AUCs, are urgent cares now. So everything felt amazing. And this was, of course, we didn't compare. There's no cohort here. So we just used the patients that we were targeting in the hospital as high utilizers. They basically lived in the hospital. So we showed great results and sold the program. Again, you will relate to this, as many of you know. I mean, our goal is to really put the patient in the center of it. And a lot of your programs are probably already doing this, but we really want to be able to provide the care for them in the medical facilities, whether it's in the hospital, in the assisted living facilities, in the nursing homes. Comprehensive office visits, our office visits are 40 minutes long, like a lot of yours. Generally, we have 20 minutes office visits, but for a complex care, it's 40 minutes. And our physicians give their cell phones to their patients and families. It's 24/7, 365 days. It never stops, and they love it. We have multidisciplinary planning, so we engage our specialists with our patients on the same day service, sometimes on thanks to technology, we do clinic visits, virtual visits with them as well. And so again, a lot of this here on this slide is repetitive, but I love this slide because it really has the patients in the middle of it, and we're truly doing this. what do we all want to achieve? We want to achieve increased clinical coordination, increased health outcomes, decrease hospital utilization, and decrease ED visits. Which is utilization. So that's on the right-hand side of this. Our inclusion criteria is interesting. When we wanted to make this work, right? So we just got into a room and we looked at our high cost model patients and we said, okay, well, it makes sense, COPD, it makes sense, cancer, it makes sense, end stage renal disease. We talked a little bit about that today. Ejection fraction of less than 20% for patients with CHF, dementia, gastroparesis. This was like a frequent visit of our urgent care. A lot of patients with gastroparesis and patients that have been in the hospital with a respiratory failure. And again, we picked this inclusion criteria just based on our high utilization model of patients that were seeking services in the hospital setting. We haven't really touched it since then, since 2017, but it might be time for an update. But I will tell you, as vague as some of the diagnoses are, we've been able to get patients in, or especially those patients that would not be able to get in if they didn't have, if I were to specify a little bit too much on the advanced cancer with meds or COPD on oxygen or dementia. Dementia is a big category, right? So functional dementia, cognitive impairment to advanced. So it's really helped with our specific organization to get referrals steady and going for us. Of course, with that, you have to have an exclusion criteria, which is pediatric and pregnant women. We've made our order entry process super easy. It was really word of mouth in the beginning. And again, I think we're still scratching the surface, although we're like 5-6 years into this. And it's all in Epic. So any physician, any nurse can see a patient at any point in the office setting or the hospital setting or the skilled nursing facility and put in a referral to complex care. We did this, on the bottom, we put complex care program, case management, or community navigator. We realized we were getting a lot of referrals for transportation support, and we're not that service, but I didn't want to leave them high and dry. So I put that here so we can help a lot of folks. And a lot of people are laughing, so you might agree. Again, I'll skip through this because of just time, but it really gets into our referrals, and it's all in Epic. Is like, why are you putting this referral? Is it for what need? And it actually goes to the right folks to get the right help for that patient. COVID was very interesting. Whereas we started, we never really stopped our operations. It never stopped for us. You can see the orange line bar here. Our patients love to be seen face to face. Telephone is in the green. But interestingly, we always thought complex care patients are high disease burden. They may not want to use video, but we were surprised. They use the video as well. And again, the jury's out on telephone and video, especially for complicated patients. We're seeing them come back tenfold. Deferred care was a real thing, I think, for us. But just to kind of point out that I think the variation of the type of visits that we were doing, we were still going to the home of the patients, not in the thick of the pandemic, but we are doing home visits again. That's a younger picture of myself. So, so Dr. Michael Horberg is our associate medical director, sponsors the program. And because they're not here, I just think it's worthwhile to show the face of our courageous physicians here. This is for the DC Maryland group, our 4 physicians supported by our research nurses who do a lot of research mining for the program, but also the first line of defense, and they want to reach our physicians. And we're supported by case management and social work. Again, this is our Northern Virginia group. We have 3 physicians there. And in Baltimore, we have 2 physicians, and we're looking to grow our program. And since the beginning of the program, we've had 4,355 patients go through the program. No surprise, 2,225 patients have died. 609 patients have just said, no, not for me, I'm leaving, or their insurance would run out. And so we have current patients about 1,521 patients in the program. So we have a healthy group of patients to do research from and really learn from. And I heard a lot about social determinants of health, and our complex case management team really prides in itself taking care of patients. So this is, we've set targets for our complex care case management, outreach to patients, medication review, and just really working with them on a regular basis. And I think, I'm not sure if that's the secret sauce. We're still struggling with social determinants of health like everywhere else in the country. We don't have the magic for that, but we're really pushing the boundaries. Again, this is a list of, I asked our case management team to give me all the things that they do, and they're doing a lot. But again, coordinating care for these patients right off the bat, right from the beginning, frequent touch points, seeing patients as they are coming to the primary care office to see the complex care physicians, seeing those patients during that same time, making follow-up calls, making sure the home health services and the DMEs are all taken care of. And again, one of the biggest things that this year we've been working on, and I have heard a lot of conversations about what are we doing for the end-stage renal disease population, is really early targeted care and life care planning, goals of care. These conversations have to have much earlier than even the referral of complex care. And we need buy-in from the entire healthcare community. Our AFM docs have to be comfortable engaging the conversations. Our oncologists, cardiologists have to be comfortable with engaging in these conversations. Only then we will see a big difference in this, I believe. And again, to conclude with our publication, our first publication, of course, showed a pretty significant survival benefit. And again, fast forward from our first publication, we are now looking into our second publication, which, believe it or not, almost replicated that study with a higher N of patients. And again, yes, we're showing a survival benefit. And I'm always intrigued by the utilization of decreased hospitalization and readmission. We have not shown that yet. But we've also not studied the longer tenured patients in complex care if they're living. My guess is that they will show a reduction in utilization, and they're probably ones that benefited the most in this study. And so we are now quickly approaching our second publication, and we're looking at the quality of life. We know that in our program, the transition to hospice is quick and easy once they get into the complex care program. We've shown a close to 28% increase when compared to non-complex care transition to hospice, and a better quality of life towards the end of life. So that's something that we are hoping to publish very soon. And I'll stop there. Thank you.
So we'll hear from our two discussants.
Sure. Thank you all for your talks, and maybe I'll throw out like the first question that I'm curious. I'm Nicole Gear, a clinical social worker. Worked with the comprehensive care program as a clinical manager for several years before I moved, and now in more of an advising role, but still play a part in the day-to-day operations. And so very interesting to hear you each talk about the ways that you've developed your programs. And one thing I was thinking about as we've been talking about buzzwords and engagement and retention and relationships and is just like how each of you, how you have thought about like your clinical team, the people that you're working with, and how the years of building a team and the investment there, like what are the ways and in which you've kind of built out communication within your team to do this very difficult work. It is complex, especially the patient care is complex, but you talked about communication being key and streamlining your work. And so just how do you keep your teams together? How do you retain them so that they can build relationships over the long term?
Down the table.
Sure. Yeah.
I think I could start. So I think one advantage we had was our team was in the same room. So our case manager, social worker, and pharmacist, we're always in the same room. So at the start, it felt very unnatural, but through time, you kind of just get to know people, and that allows you that, conversations to happen very naturally. And the time that we've been together is so long that we've kind of learned each other that, there are good days, there are bad days. So you kind of, are in this together. And then one thing that I think I really wanted to be sure of is first creating a culture that everyone is like, has a voice. And my job, as a director was to pull people's voices into the program because that's how I get engagement. As a physician, I know I have a privilege that, my voice is stronger, especially in an academic institution. So I think my job is to kind of bring other voices and elevate them. And then the second thing that I think I really wanted to be intentional about in our group was to really create a culture of trust. And you can't force people to trust you. You can just only try to be trustworthy. So I'm transparent, like everything, like all our data is out there and I'm consistent. So I think I tell them up front, okay, these are my values, this is what I do, and I really make sure that I kind of follow through. And then if you think about the relationships that you have in your life, that's what you're looking for anyway, right? So I just try to be, a trustworthy person. And I think so far, my friend, like my colleagues right now, or my friends are here, and I think that's, tells them that, they trust me, I think.
I agree. I would love to work with you. You seem to create a very welcoming environment, and I think that's the key is, I think I agree the physician tends to have the leadership role like automatically dumped on them maybe, but we're not always equipped with all the information that we should have in order to make the best environment for our patients' care. And so I think it's good to be humble and I really thought that the AmeriCorps members were invaluable to our existence. For instance, food insecurities were not something that I routinely screened for, but I mean, what a huge impact that has on your health. And so once I was part of CCP and I could see the incidence of that, it shocked me, which shows my naivety in, all the years of my practice. But that's just an example of how I appreciated and I conveyed that appreciation to those AmeriCorps members in gaining that insight and then being able to take steps with our social workers or case managers to provide, and the AmeriCorps members did as well, all of the resources that were available that these patients didn't know about. So I told a couple people that I wish I had a longitudinal study. I wish I could have been part of an academic study many years ago, because I think I pushed for primary prevention in my patients, and lifestyle issues, especially food issues, I think have such a big impact. And our team just kind of coordinated in all that to make it okay to express concerns. And I think patients felt that. That's what we're looking for. We want to know, what are the problems you're having? We want to be your coworker in solving them. So I think if you come at it with that perspective, everybody jumps on board and is appreciative of the efforts, and it makes for a smooth transition.
Yeah, thank you for the question. I think I agree when you accept this sort of a leadership or it's given to you, you have to normalize outside of the box thinking with your team and even with yourself. And you have to understand that outside of the box thinking can be very expensive, or it can be really cheap and easy. And you have to put yourself in that position and sell that to your team. And for instance, it really resonated with me when you said you have old guards and allies, right? And because every organization will have that. And I still, even to this day, we have folks thinking that we're not doing anything, or like things are not moving along as what they wanted it to. But and you just have to surround yourself with allies. But again, be persistent. And I think our physicians are doing a lot of the legwork. Our complex care teams are doing a lot of the heavy holding, and continue to empower them and encourage their ideas. There's so many ideas all the time. We have a regular cadence of meetings that I hold on a monthly basis with all just the physicians and the entire complex care team And then quarterly, we're meeting with our executives and sharing with them. And a lot of the stories, and I always say, share with me what you've done in this week, because to quantify some of the things is very, very difficult, as you know, in this room. How do you quantify trust, right? When I walk into the room of one of our complex care physicians, I see on the wall so many letters from patients that they've received. I've seen that they've gone to and spoken at funerals, and they've gone to birthday parties, and they've had gifts sent to them, or just recognition of even their own birthdays by their patients. So if you're telling me that this is not meaningful, then there's a disconnect. So really, our jobs as leaders or folks in this space is to make sure that we point that out every time we get an opportunity to, and share those stories. They may not be quantifiable because we're sending, 3 patients to the hospital, but we're avoiding 7 other hospitalizations sometimes, which go underneath the rug. And so we've started doing that a lot this year, and I think it's really helped with the morale of the group.
So I'm wondering if we could hear from Walter in terms of the patient perspective on all of this.
From my perspective, to make a testimony to the services of comprehensive care. Prior to being in comprehensive care, my medical services were with the county, and seeing a lot of different doctors. And every time I saw a doctor, not seeing the same primary doctor, it was really hectic. And as a professional musician, I brought my daughter up, and she, through high school and before college, she had the same services, and we could never get a consistency with doctors. And, when it comes to your care, it gets lost. At one time, I was legally blind because of my cataracts. And 2014, 15. And that was due to the care that I was receiving. I was following up, but the doctors were so overloaded with their work that they were overlooking things and misdiagnosing and pushing things under the rug. And I would come back and start all over again. And part of that was an insurance thing too, but because the time lapsed and I knew I had cataracts, I was blind, and I had to be escorted up 2 stages. I had to stop driving. It was very hectic, but after that, I got my cataracts put in. But at that time, I transitioned into comprehensive care, and because of my sleep apnea and my arrhythmia, there were problems there. But since I've been in the comprehensive care and having a consistent primary doctor, that has given me continuity to my health. And at one time, the arrhythmia had it was more like acute, and but I got the services with the comprehensive care, and that eliminated that. And then there was the cataracts that was over. So, but in the last year, I was hospitalized last year, and because my doctor, that was my primary doctor, she saw me. She would come in and see me in the hospital in the afternoons. No, she was morning. I can't remember if it was morning or afternoon. I was so sick. I can't remember. But she would come in every day, and then I think she was off for one day, and that was it. And they built a team around me. So with the rheumatologist and the cardiologist, they were interfacing with the cardiologist, and it was just a team. And it gave me a lot of comfort and I would say confidence in my care. Whereas prior to that, I was, as I said, 2014, it was crazy. and it was a fight and it was a battle. And I would have to take care of all my data and all my medical information, keep track of that and take it to each doctor and start all over again. And now it's a lot different. It makes it easier for me. And I think it makes it better for me as well. And being in the comprehensive care and being a patient, interacting with the PCORI and the patient community board and the activities that they have to meet our unmet needs, social needs. That I try to get other patients in, but there's always insurance glitches that we have to, hurdles that we have to cross over. And a lot of times they can't be accepted into the program. And they are having problems that I had previously. But as you say, getting confidence, it's strange is that they're not getting good service and they stick with the service, poor service they're used to, because they don't trust crossing over to another service and trying to share my experiences with other people. They listen, they like it, but they're just not comfortable with switching. So it's a battle to convince people that it's better to have a steady and primary doctor than keep getting different services. And I'm a senior, as you can tell, and most of my friends are seniors, but they really lack confidence in the hospitals that they go to. I won't name the ones that they go to, but it's when I talk to them over and over and over again, it's complaint after complaint after complaint. And some of it I think is some of the reason that they don't follow up with the services that they get too. I can't say it's always the institution that they go to, but
Thank you. That was very.
okay.
I'd like to thank the panel for some great presentations and discussions. And what we're going to do next is we're going to break out into 3 groups. And before we do that, by the way, I'm Fran Weaver. I'm a professor in public health at Loyola University and a career science in the Department of Veteran Affairs. And David asked me to talk a little bit about implementation science framework. And when he asked me, I said, there's over 100 frameworks. How am I going to pick one? So I went to the Consolidated Framework for Implementation Research, or CFIR, because what CFIR does is it takes all those frameworks that are out there and identifies the key factors in the different components that you should be considering whenever you're going to take a program and try to implement. And if you talk about implementation, we're talking about change. So, Walter's example about how a lot of his friends don't want to change to a new program, the comprehensive care program, is because change is hard. Change is uncomfortable and it scares people. And that's true with implementation too. It's hard to take these programs and put them in place. There's things that you need all kinds of things you need to consider, and that's what's in this diagram. And we talk about facilitators and barriers. So the facilitators are the things that you grab onto that can help you, like the friendly IT people. And the barriers are the things that you need to either get around or somehow overcome, like those saboteurs that are sitting there in organizations that don't want to change. So when I think about this approach, in the middle, you have the individuals involved. In the case of comprehensive care, one, it's your target population, your high-risk patients. But the other group that you should consider are the providers, those individuals that are going to be doing the program. They are also critical to this. And so in every case, our panelists talked about pulling in those providers that were willing to do this, that they saw the vision, that they saw this was important. So, thinking about things like stage of change, are they ready to make a change? Where are they? Do you need to meet them at the point that they are? What are their knowledge and beliefs? How do they identify with the organization and other kinds of personal attributes? So that's sort of in the middle. And then all the things that feed into it. So the intervention, it's that thing. In this case, it's comprehensive care. So what kind of evidence do we have? Well, we're building the evidence, starting with the work that David, started and then building on it with all these other programs. How does it relate to what we have out there right now in terms of competitive advantage? Can we adapt it? And I think we heard today that you can adapt it to, fit the population that you have. How complex is it? This is kind of complicated, but you have all shown that you can make it work. Trialability, can you do it more than once? The process is, how are you going to do this? What help do you need and what can you use? So you think about clinical champions. Are there people out there that are going to really be your cheerleaders? Engagement. Can you engage people, particularly leadership? I think it's very hard to get anything changed in a healthcare system if you don't have the leaders involved. Opinion leaders, change agents, reflecting and evaluating, kind of this, quality improvement, continuous quality improvement. The inner setting. So what do you have in terms of the culture and the climate? Is it a situation where, they're very proactive? They want to make change. What kind of structural characteristics are there? Are there things that are going to get in your way that you're going to have to address? What kind of communication do you have? And how ready is that organization to make those changes? And then lastly would be the outer setting. So these are the things that are coming from the outside that really are affecting your ability to do this. So it might be your payment mechanisms, your competitors, politics. So here are some examples here. What are the incentives to do this? What are patient needs? So you've identified in this work that there are patients who really have a need for this kind of program. And then peer pressure. Is there pressure being put on from the outside to make these changes? So I just want you guys to keep this in mind when you think about taking a program like this and trying to put it in your own organization. So what we're going to do now is we're going to break out into 3 groups, and you can decide what group you want to be in. So we have one group that represents the institutions, the hospitals, social service agencies. A second group would be providers, and our third group would be patients. And we're thinking maybe, just divide the room in thirds. So you kind of pull your chairs around the table. These are the 2 things we'd like you to think about and discuss in your groups. Keeping the CFR model in mind, what do each of the perspectives and stakeholders need to do better to support the others, given that interdependence of all 3? And 2, what should be considered when developing implementation best practices for these comprehensive models? So think about what group you want to get into. Institutions, providers, patients. Thank you.
Great, so we've got about, 15, 20 minutes for this part of the discussion, and then we'll pull the report out. That's the plan?
Yep.
Okay, and people can, if they want, to just leave their stuff, and I think that's probably easiest. You good here if you want it. And some of us will hang back and do it, whichever people's smaller. I think this. It's gonna migrate. Okay.